And good morning, it's October 3rd, 2023. I'm Dr. Deuk. We're getting ready to start our second surgery of the day. Our patient is traveling here from Kentucky, Lexington, Kentucky. Louisville, I apologize. Louisville, Kentucky. And she has suffered with back problems like back pain for a lot of time, 50 years I'm being told. She's had a fusion already in her back at L5-S1, and we're going to be working on the L1-2, 2, 3, 3, 4, 4, 5. 4 discs, all on the left side. There are herniations and degeneration. So we're going to get started. Our first step in the surgery is to get into those discs with a transforaminal approach. So I've got to find the right entry point into the body. We'll start here and see where that lines up. Shot. And we're going to be using our x-ray machine to navigate. I should be able to get 2 or 3 discs with this one. We're going to be treating 4. This looks pretty good. She's comfortable. She's not really responding, which is nice. Means that she's nice and asleep. I'm giving her some numbing medicine, which will block pain impulses where we are in this area. Shot. All right, so I'll start at the L4-5. You can see on the MRI and the X-ray shot that the L5-S1 disc is fused. She had a fusion done, I think, back in the 80s, correct? 1983 is what I'm being told. Shot? So the problem is when you have a fusion, you get what's called adjacent segment disease, which is basically shot. The joints above your fusion, one more shot, AP, and even below the fusion can become worn out, arthritic, and painful. So she's definitely has problems above her fusion. Show the fusion mass. Boy, they really put a lot of bone there. You can see all the bone there like a silhouette. A huge amount of bone that those surgeons put there. Okay, let's go back to a lateral. In my opinion, way too much bone, but I didn't do the surgery, but I have to deal with the aftermath. Shot. It looks like the facet joint's got a lot of arthritis as well. You can see that's right where the needle is.
Where
Shot.
are you feeling that? In your back?
Yeah. You're doing great. Shot. Where do you feel that?
Where are you feeling that?
Shot.
Where? Tell us back or leg. What? In your back? Where? I couldn't hear you. Say it again.
Shot. In her back, I think.
In your back?
So we're into the 4-5, which is great news. I'm going to make my incision, but a little bit more numbing medicine first. We're going to give you some more numbing medicine, dear. So we'll make our incision now that we've gained access to the most difficult disc to get into, which is the, hold on, L4-5. You can see the L5-S1 is fused. Why don't you show us the fusion, Jordan? Thank you, Louis. Shot. All right, let's see the L3-4, which is our next disc. I think we're off on WAG. You see the double shadow on the pedicle of L3 and L4, so you're off on the WAG. Shot. Why are you moving further south, Jordan? It makes no sense. Move your fluoro north and fix the WAG. What are we hitting there, guys? Are we hitting the arm board? We shouldn't be. The arm boards are supposed to be as far north as possible. You gotta fix the wag, Jordan. I think that's definitely better, but it's not perfect. Let's go 1 more degree on wag. You're doing great. I need you to lay still. Shot. All right, good. That's really good. That's as good as we're going to get the wag. For those of you who don't know what wag is, it's the movement of the machine, the x-ray machine, in one side moving up or down on the patient. Shot. That's it. Okay. Lay still. So I'm sneaking past her facet joint at L3-4. Again, full of arthritis. And now I'm at the herniation. Shot. And I could feel the herniation. AP. She has an allergy to iodine, so we're not using any iodine with her. Oh, it's perfect. You could see the tip of the needle is right at the back of the disc at L3-4 on the left side. After this, we've got 2 more to get. But yeah, I can feel the bone spur. Shot. I've got to try to get into this disc. It's very collapsed. Shot. Well, we're right at the back of the disc where I want to be. I just can't get it to pass in because there's pretty collapsed space. So I may wait till she's a little more asleep and she's not tightening up her muscles quite as much. In the meantime, I'm going to try to do the L2-3 here as well. Shot. All right. If I can get the L2-3 here, that would be wonderful. And then I just have to make 1 more incision for the 1-2. What I'm talking about, for those of you who don't know, are discs. We're treating the L1-2, L2-3, L1-2, L2-3, L3-4, L4-5 discs. Shot. Thanks, Louis. Shot. Just sneaking around the facet. Once again, the facet joint is full of arthritis. Shot. Just about there. You can see the tip of the needle at the back of the disc. Very nice. We're able to get 3 discs with 1 incision. I just need to get in a little further. Yeah, she's severely collapsed. These are degenerated discs, by the way, but it doesn't matter whether you have a bulging disc or a degenerated disc. On your report, the procedure we're going to do is effective at getting rid of the pain from even degenerated discs. There we go. You're doing great. You can see the needle bending to get in. All right, and then the one below. Still can't get into the other one. We've lost about 5 drops of blood the whole surgery. It's not much. She's doing fantastic. Our anesthesiologist is doing a great job as well. Okay, so we've got 1 more disc to go to. I am going to have to go to a new location to start and get through the skin. So I'm going to reposition where I'm going in. I'm going to go further north. Lay still. You're doing great. We're almost done. We're going to put you to sleep soon. But I need you awake for this part. Shot. Yeah, thanks, Jordan. Let's see where we are here. Shot. Uh-huh. Okay, not bad. I could just probably come a little bit lower. There we go. Shot. All right, that's lining up quite nicely with L1-2. Shot. just got to get around the facet, shot. I'm almost there. And to do that, I have to redirect, shot. You see me going back a little bit with the needle and then going forward again, shot. And what I'm doing is I'm going just a little bit more lateral each time. Shot. I may be hitting, there we go, AP. So we're now at the back of the L1-2 disc, right in the foramen on the left side where the herniation is. This is the last disc we're going to be treating. Yep, looks good. So I was hitting the transverse process of L2. If I'm not able to get past it, I would have to go further north towards the head. Are you comfy? Are you having any pain? Shot. Are you having any pain?
How are you doing? Pretty sleepy.
Thank you. So, folks, at this point, I feel good about our access to all the discs except for L3-4. L3-4, I couldn't get into the disc space, but I'm right behind it. So I still should be able to do the surgery when she's asleep. She'll be more relaxed. Her muscles along her spine will relax, and they won't be as tight. Tight muscles in your back will cause your discs to squeeze down and discs to bulge out and nerves to get pinched. So muscle spasms can actually cause disc symptoms to be worse. And disc symptoms cause muscle spasms to be worse. So it's kind of a vicious cycle. That said, we know that the L4-5 is abnormal, degenerated, L3-4 more degenerated, L2-3 once again degenerated, and collapsed in L1-2. Now what we are not able to do today is we're not going to use any dye that you'll be able to see on the x-ray because she's allergic to iodine. And we don't want to give her any iodine. But we can still do our discogram when she's awake. How is she, doctor? Almost there?
How are you doing, my friend? You okay? We're going to ask you some questions, all right?
Are you having any pain?
Can you open your eyes? Good. Open your eyes. You having any pain right now? Any pain right now?
You can see her scar from her prior fusion. Yeah. So the surgeons that did her fusion at L5-S1, they did it because she had what's called a spondylolisthesis. Her bones were slipping. She had that done, I think, in like the 1983. That was a long time ago.
40 years.
That was 40 years ago she had that fusion done. She's had back pain for 50 years. So the surgeons did what they could back then, which was a fusion at L5-S1, and we saw that fusion mass. You can actually see it on the side view as well. Jordan, Henry, go to the x-ray view, and you see that all that bone there. Jordan is highlighting it for you. That's all bone that shouldn't be there. That's called the fusion mass. Now show us the L4-5 facet. You see the, yes, right there. You see that line, that white line right there where we're outlining with the arrow? That is the facet joint. It's definitely not normal. And then look at the 3-4 facet. It's not normal either. Yeah, there you go. So she's got not just degenerative disc disease, but her facet joints are also enlarged, we call it hypertrophy, and arthritic, full of bone spurs and arthritis. It doesn't mean they're causing pain. We don't know that they're causing pain. If we did, we'd be treating them. We don't think they are, but we could be wrong. And the only way to know is to fix her discs, and then we're going to find out if she still has any residual pain. Are you okay?
How are you doing?
Don't move.
She said yes, she's okay.
Are you having any pain?
Are you having any pain? Yes or no?
No?
Yes or no?
Are you comfortable?
She said yes.
All right. How bad is that on a scale of 1 to 10?
Give us a number. 7.
The highest it goes. What's the highest it goes? Ask her.
A 10?
10. Is that where you typically get back pain? Is that where you get your back pain? Yes, she had a 10 out of 10 at L1-L5. 10 out of 10, and it's concordant, meaning it's where she gets her back pain. Now, you're not going to see, folks, on the x-ray, you're not going to see the discogram and the tear like we normally do, because that requires the use of a contrast media that contains iodine, which we're not using in her case. Are you better now? All right. All right. How bad is that on a scale of 1 to 10? What's the highest it goes?
9.
9.
9.
So I heard her go, 9. Is that where you get your back pain?
Yes.
So a 9 out of 10. That's called 9 out of 10 concordant. That's L2-3. L2-3. I'm not testing L3-4 because I don't have the needle in the disc, so I'm leaving L3-4 untested. But we're still treating it. So we got a 10 out of 10. We got a 9 out of 10. Are you better? You better now? All right.
Okay.
You see that? Ow, ow. How bad is that on a scale of 1 to 10? How high does it go?
9.
Is that where you get pain? 9 over 10 at L1-2. Concordant. Okay, great. We got to put her to sleep. Doctor, please take your time. I see Luis has come prepared. All right. Henry, let's show the audience, why do people with disc injuries actually get so much back pain from those discs? Whether they're herniated or bulging, whether they're slipped or protruded or extruded or ruptured, it's all the same. You get back pain from a disc, and it always comes from the same place. Henry, let's show them. Okay, welcome back. You can see why discs actually cause so much pain. There's a tear that happens in the back wall of the disc called the posterior annular tear. This was discovered at Deuk Spine Institute 17 years ago, and we've been treating these tears for 17 years. We've published our results, and the problem is that, well, doctors are being taught to ignore the sources of pain and just to do fusions and laminectomies and, horribly invasive surgeries. But at Deuk Spine, we're actually treating just the source of the pain, which happens to be a very small spot in the disc, which you can see on that video. And let's show our audience, Henry, how we fix those tears and get rid of the back pain that comes from the disc. Okay? Welcome back. And we are now started removing the pieces of herniation. Here's our first one. This is at the L4-5. Can you see this, Henry?
Yes, we can.
I dropped it. Oh. It's somewhere out here. Okay, well, we'll have to get some more. We're using a tiny tube that's 7 millimeters wide. Oh. And the tube is giving me access to the herniation, which is right here. That's the blue thing you're seeing. And I'm going through a tear that's already there. The tear is called the annular tear, which you guys have already seen, is in the back of the disc. And that's where all the pain comes from when you have a disc herniation, a disc protrusion, a disc rupture. It comes from this tear. Yeah, I think we are a bit overexposed. You're right. So thank you. If you could turn it down one notch. So now I'm going to bring our laser in. Our laser is 1 millimeter. It's still a bit overexposed. Do we turn it down? I don't think we did. There we go. Perfect. Yeah, thanks. All right, so you can see the laser fiber, the glass fiber, it transmits energy from a laser machine, which is located here in the operating room at the patient's feet. That fiber transmits laser energy, which is invisible to the eye, right down to the herniation. And what we're seeing here at L4-5 is a very kind of old herniation. And there's a mixture of some new and some old. Okay? But the stuff I'm in right now with all that white scar tissue and the little white flecks, that's calcium. That's called dystrophic calcification. It's only found in chronically damaged tissues in the body, tissues that have been damaged for many years. So clearly this disc has had damage for many years, and that's why we're seeing those white flecks. Here's a herniation. Watch your finger. All right, so I'll just put a little pile and we'll look at them later. All right. But the grabber goes in and pulls out little pieces of herniation like that blue one. Now that's a newer herniation. That's why it's fluffy blue. The older herniations are more scarred and white. I'll bring the laser back in. And I know we have some questions. I'll take the questions while we're using our laser to do the annular debridement.
These two questions come from Vitality Approach on YouTube,
All right, I like the name.
and they ask if the annular tear ends up being too large and doesn't heal well on its own after debridement, is there anything you can do, or does the cauterizing action of the laser solve that?
That's a great question, Fatality Approach. We've never encountered an annular tear that cannot heal from the surgery. Every single one of them heal. The reason why the annular tears don't heal naturally, it's not because they're big, it's because this blue stuff right here is stuck inside them. And that blue stuff is the herniated disc. It's actually, we call it the herniation, but it is nucleus pulposus. It's a jelly found in the center of the disc. It's not really jelly, but it's a firmer, wet material, very distinct from the annulus fibrosus. The annulus fibrosus is a tough outer ring of tissue that's made of collagen and elastin. The nucleus pulposus is not made of collagen and elastin. It's made from proteoglycans and glycosaminoglycans, which are very different types of molecules. And when the proteoglycans and glycosaminoglycans push out into the tear in the collagen elastin wall, they elicit an inflammatory response. They make the body fight them. They're basically saying to your inflammatory system, hey, we're escaping, come get us. We want to fight. And the inflammatory system says, sure, I'm down for a fight. And it attacks them inside the tear. And then all that fighting and attacking of the inflammatory system against the proteoglycans and glycosaminoglycans of the nucleus pulposus is what causes all the scar tissue and the calcium deposition that you're seeing, little white calcium. So it's that material, the scar tissue, the proteoglycans, GAGs, the blue stuff, that prevents the annular tear from healing, okay? And it's the source of all the back pain. Once we remove it with the laser from the tear, then the annular tear can heal. Now, people always ask me, do you ever see it on MRI? It's a very small thing to see, and MRIs really aren't able to see these healing of the annulus, okay? That's why we don't bother ordering MRIs afterwards, because we're not looking for a MRI verified healing. You will never find it. Maybe someday MRIs will be able to see small tears and small areas of inflammation. Right now you can actually see areas of inflammation on the MRI. They're called high intensity zone, or HIZ. All right, here's some old herniation, the white stuff, it's all scarred up, and then the blue stuff is the newer herniation, more recent. So this disc has been herniating and reherniating for many years, and probably 50 herniations, if I had to guess, over the last 50 years. At least a herniation a year. Our average disc that we repair has 30 herniations, we find. 30 independent little pieces of herniation, which means the patient herniated 30 times on average in their lifetime. And every time your back pain gets worse and it fires up, you know, after doing some activities, that's another herniation. And it's causing inflammation to happen again. And then it dies down for a while until you do something else to set it off. That's the cyclical process that Deuk Spine Institute's the first in the world to discover. We call it elucidate, means to shed light on it. Unfortunately, most doctors don't know about this process. We've been talking about it now for the last 17 years, trying to teach everybody about it. And we've gotten better at teaching by making these videos and broadcasting over the last 10 years. So if you go to our YouTube channel and you start looking on YouTube for Deuk Spine Institute videos, you're going to find that we've been broadcasting these surgeries now for 10 years, live. All right, we'll take another question.
Next question comes from Vitality Approach, once more on YouTube.
All right.
They asked, how is success defined with these procedures? Pain-free after surgery, or continuing to be pain-free after time, or no reherniation? What do the percentages look like at the 5 and 10-year follow-ups?
That's a great question. That is a really good question. So success for us is defined as elimination of symptoms from the disc that we're treating. Now, for example, if we fix your L4-5 and you're pain-free from L4-5, but you come back with pain from L5-S1, well, we didn't treat L5-S1, so we're not going to count that pain at L5-S1 as a failure at L4-5. You'd have to have pain back at L4-5, which doesn't happen. So the success is based on the elimination of symptoms from the disc at the discs that are treated. So it's tricky because you have to know what discs are causing what symptoms, and that's really the hardest part of this surgery, is to actually not the surgery, but treating any patient with chronic back pain. You've got to know where the pain's coming from. There are 30 different sources of chronic back pain, and our new website that we're developing is going to show you those sources, so it's very easy to see and understand. Our existing website doesn't. We just know about them and we try to teach people without them, but the new website's going to actually have interactive animations that will teach you all about the 30 different causes of chronic back pain. So success for this surgery is elimination of symptoms from the treated disc. To know if you're successful, you've got to know what symptoms you're treating from this disc. So what are the symptoms? Number one, back pain from the disc. that we're treating. Number 2, leg weakness, numbness, or tingling from the disc that we're treating. And number 3, sciatic pain down your leg from the disc that we're treating. So that's how we judge success, is the elimination of the patient's symptoms. As far as long-term outcomes, as you know, most spine treatments don't have any long-term outcomes. That's because there are no long-term success with most spine surgery. However, with the Deuk laser disc repair, we've peer-reviewed and published our outcomes, and we have 6-year follow-up on average with I think it's either 92 or 95% of the pain is still gone. But it's over 90%. So that's the most successful long-term surgery in the world for spine, for back pain. There is no study that shows better long-term results than 92% elimination of preoperative back pain from the discs we're treating at 6 years post-op. So excellent results. Our reherniation rate is 1%. That means that 1 out of every 100 patients is going to reherniate. And unfortunately, it's usually because the patients do something they're not really supposed to do too soon. So there are restrictions on activities after the surgery. And some of our patients do things that, unfortunately cause a reherniation. And we see that 1 out of 100 patients. Typically, if they reherniate, their patient will tell you they did something, and while they were doing it, they felt a pop in their spine. And then they had pain and symptoms that came back. So this surgery is not without reherniations, but if the patients typically follow our instructions, then the reherniation rate goes down from 1 in 100 down to 0.1 in 100. In other words, almost all the reherniations, it was due to patients not following their post-op instructions with restrictions or wearing their collar. It happens. Great questions today, by the way, and I appreciate the audience being so engaging. This is the tear. It's very scarred. A lot of white stuff indicating scar tissue. And I'm twisting and moving my tube backwards towards me out of the herniation. So the tip of the tube started deep inside the annular tear at the bottom or deepest part of the annular tear where the herniation started. And now we're pulling it backwards towards the most outer part of the annular tear and herniation. And along the way, I'm cleaning the wall. We call this a debridement. I'm debriding the annular tear. Keep the questions coming. I'll be happy to keep answering them for you.
Next question comes from Big John on YouTube.
Yes, we have a verified Big John on YouTube.
Big John asks, you have been doing DLDR surgeries for over 10 years. During this time, what have you learned or do differently today than when you first started, and why does that benefit your patients?
So, Big John, thank you, and always appreciate your questions and involvement. So Big John's question, and by the way, we've been doing the DLDR for 17 years here at Deuk Spine. We've been broadcasting for 10 years because before that we didn't have the broadcast equipment or the resources to do that. Otherwise I would have done it a long time ago. But long story short, what am I doing different? There's several things we've done different. Number one, Luis introduced me to this bigger laser fiber. This is a 1 millimeter laser fiber. We used to use the 0.5 millimeter which was, you know, a lot smaller than this one. And the laser would take longer to do the work. So now with the bigger laser fiber, we're able to get the surgery done quicker, which is always better for patients, right? Because then they're under anesthesia for a shorter time. And the bigger laser fiber and the shorter surgeries allow me to treat more discs. So we're always limited to about 2 hours with this type of anesthesia. And now with the more efficient laser fiber, I'm able to do surgeries almost twice as fast. So I can actually treat more discs. I used to limit the surgery to 2 discs years ago, and now I'm doing up to 6 spots, 6 areas. So that's another change, is my comfort level with doing more in one sitting rather than making the patient come back and do a second and third surgery later on. So that's better for the patient. It's better for everybody. It's less expensive too, to be able to do the whole surgery in one sitting rather than breaking it up. A lot of surgeons these days will break up your spine surgery into 2 or 3 surgeries. We try to do everything in one. So another thing that's improved is the anesthesia. Our anesthesia has gotten much better over the years because we're starting to use the medications that are available better. We have better medications. We use them in a better way that's more efficient, safer for the patient. We're using CPAP now for our patients to help them ventilate, which we weren't doing in the past. CPAP pushes oxygen and air through their airways so that they ventilate nicely during surgery. We have, I think, better quality anesthesia. The anesthesiologist is better. So we have a top anesthesiologist now. We have better nursing, for sure. You know, when we started out, the nurses were good, but they're really, really good now. And we're doing a lot more volume, so everybody's kind of used to what the patients need pre and post-op. So there's a lot of improvements, not just in the DLDR technique, but in the supporting anesthesia and supporting staff and medications and laser fiber. And the laser we're using is the same exact machine that we used in the beginning. It's a Luminous. It's made now by Boston Scientific. They're a bunch of crooks. They are going to stop production of the laser soon, but they're trying to sell more expensive lasers. I think I talked about that a few weeks ago. Really not happy with them. There's a tear right there. We're just about done with this one. Let's see what else has changed. I think that's pretty much it. Can you think of anything, Luis? I mean, we've started adding on the facet treatments, the DPR. There's the tear right there. You guys see the blue? That's herniation within the tear. So I've just got to clean these last bits up and we'll be done. And then we'll move on to the next disc. But we've started adding other procedures on during the DLDRs, so we're not just fixing the disc. A lot of our patients have sacroiliac joint pain or facet joint pain along with their disc pain. So we're going to do their facet joint Deuk plasma rhizotomy at the same time. We're incorporating additional treatments into the surgery so that the patient only has to go to sleep once. In the past, we would do all those as separate procedures, and the patient would have to have 2 or 3 different surgery days and 2 or 3 different anesthesia sessions, which I think this is better now because we're getting it all done in the 2-hour time limit that we need. Am I missing anything here, Dr. Berndes? I think I covered pretty much everything. Anesthesia, staffing, equipment changes. Just, yeah, that's good. Good question. I really appreciate it. That's the first time.
Surgical and anesthetic complications with fusions, anterior, posterior.
No, they're just asking how the DLDR has changed over the last 10 years, 15 years. So I think I got most of it. May have missed a thing or two, but that's most of it. Good question, John. Big John. All right. You have any more questions, Henry?
Yes, we have about a dozen questions, actually.
A dozen
Yep.
questions.
This next one comes from Vitality Approach, once more on YouTube.
Uh-huh.
And they asked, are the HIZ that show up on the MRI considered a visual of the annular tear,
Yes.
inflammation, or both?
Yes, both. So the HIZ, that's a great question. So the HIZ is the high intensity zone seen on MRI in the disc wall of the disc. That is inflammation within the annular tear you're actually seeing. Now, we don't always see HIZs when there's inflammation. As a matter of fact, the MRI has to be just perfect, has to be lucky to capture the HIZ. But we see them quite often, and those are areas of inflammation within the annular tear. That is where the back pain is coming from. But be careful, because you may have a patient with 3 herniated discs, only one shows an HIZ. That doesn't mean you only fix the one, because the other ones are likely causing pain too. You just don't see the HIZ. HIZ is high intensity zone. Why don't you put that there, Henry? HIZ equals high intensity zone, and it's an area of whiteness on a T2 weighted MRI in the wall of the disc. Just about done here. This is now I'll tell you, this is L4-5. Most doctors would look at this L4-5 on the MRI and they would not treat it. They would say there's nothing wrong, it's not bad enough to do anything, but definitely this is a painful disc. L4-5 was what, 10 out of 10? You guys remember? What was L4-5? We wrote it down. Who has it? What was the L4-5 disc? What? 10. Yeah, so this is the most painful disc she has. And most doctors would have ignored it. I'm just telling you. They would have treated the other disc and left this one alone. That's why it's so important. More important than the surgery is to have the right diagnosis. Yeah, you want the right type of surgery too, but you got to have the right diagnosis, because the diagnosis tells the surgeon where to operate. So if you're thinking L4-5 is not a problem based on what you're seeing on the MRI alone, then you're basically not going to treat L4-5, and yet that is the most painful disc she has. You would have made a mistake not treating it. She still have pain. Then you send the patient to pain management. I don't know why you're having pain. My fusion looks really good. It looks good. The screws look good. The rods look good. You're just crazy. Well, the patients aren't crazy, buddy. It's the doctors who are crazy. All right. You guys like it when I pretend I'm a jarhead? Not a military jarhead. Marines are good guys, gals. I'm talking about just stupid doctors. What's next?
Next question comes from Bali on Facebook.
I'll take the question in a second. I just want to tell you, all this stuff I've been working on here, all this white stuff is dense scar tissue. It is thick, hard, very hard for the laser even laser can get it, but it moves away from the beam. It like jiggles away, unfortunately. So, and it takes a lot of energy to break it up. See, what's happening is the laser is literally fragmenting this tissue into small pieces. You see that? You can see them breaking up. So that's what laser does. It breaks up the bonds of the proteins that make up the scar tissue. Scar tissue is primarily collagen, and collagen is a protein. So what we're doing here is we're delivering to that scar tissue energy. And the scar tissue takes the energy, and then it just literally rips the proteins of the scar tissue up into pieces, breaks it up and fragments it into little pieces. And so that's what we're seeing happening. Okay? Just about done. I'll take the question.
This question from Bali on Facebook. They asked, "Hi Doc, I read that a disc can re-herniate after treatment, like a fusion, etc., with your laser repair. Is there a chance for a re-herniation to happen, or no?"
Yes, 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 yes. The re-herniation can happen with any spine surgery. It's less likely to happen with a fusion, usually, but even fusions you can have re-herniations if the surgeon didn't get all the disc out of the disc space, which is quite common. So I would say the lowest chance of re-herniation is the Deuk laser disc repair, what you're watching right now. It's 1%, but it's not 0, it's 1%. 1 in 100 will re-herniate, that's our number. And we even see re-herniations in the last year. I've had a re-herniation or two. And that's a piece of herniation right there. So we're pretty much done with this disc. The reason why people re-herniate, in my opinion, well, we have a little more, never mind. The reason why people re-herniate with this surgery at 1% is mostly because they don't follow instructions. We give people very strict restrictions on bending and lifting. For example, this type of surgery you're watching, the patient is not supposed to bend at their waist for 3 months. Okay, not bending over to pick anything up. And the patient's not supposed to lift over 25 pounds for 6 weeks. And then it goes to 40 pounds after that for 1 year. So basically we give pretty aggressive restrictions that if the patients follow them, they'll do fine. The other thing they're not allowed to do is contact sports, you know, like grappling, jiu-jitsu, things like that, football. They have to let their disc heal. As long as they let the disc heal, it won't re-herniate. Okay, we're done with L4-5. Next, we're going to do the L3-4, I believe, or maybe L2-3. Right, Luis? Scope off. All right, I will probably do that. Oh well. But yeah, no iodine, right? No iodine. Yeah, we're not using our betadine today. So far, I want to point out the incision for this surgery is 7 millimeters. Can you guys see this, Henry?
Yes, we can.
This one's a little bigger. It's about 10 millimeters because I had to do 3 different needles. So you got to make it a little bit bigger. But if you're just doing one disc, it's 7 millimeters. So that's tiny, guys. That's like a little bit over 1/4 inch. And yeah. And basically, it's also a bloodless surgery. We don't have really much bleeding at all. So far, we've lost probably 10 drops of blood. All right, we got a few pieces of herniation right here. Let's just show the audience real quick. Can you see this, Henry? Now, we've got more than this that came out, but these are 3 good-sized chunks. You can see them. There's the ruler. There's other ones, like little ones, all over the blue towel, but they're smaller. We don't really collect them. Here's another one right here, kind of laying around. Okay? All right, let's bring the fluoro in. Next question.
Next question comes from Jane on YouTube.
You can take those, Louis. All right, Jane, we'll take your question.
She asked, are the patients awake during these surgeries?
Great question, Jane. Yes, this is considered awake spine surgery. However, they're not awake for the entire surgery. They're awake just for the beginning while we put the needles in so that I can have the patients help guide the needle. I need the patient to give me feedback. I need to know that I'm not too close to a nerve. I don't want to damage a nerve. So the patients tell me, hey, you're too close. And I respond to their input, their feedback, basically. So right now, she's completely asleep. And we want to keep her comfortable and asleep for the rest of this surgery. Yeah. So I'm trying to get this needle in at 3/4 shot. And I've been playing with it. You could see the tip of it is just at the back of the disc. And she is asleep. She's more relaxed. I can feel it. But she's not quite relaxed enough for me to get that needle in yet. So I'm going to go with the 2-3 disc next. And then we'll come back and do that one last. And then, of course, we have L1-2 as well. All right. Great questions so far, folks. I appreciate you asking them. Now I'm going to just bring this dilator. For those of you wondering, we don't cut anything under the skin. It's all spread. And we use this tool right here called dilator. It looks like a pencil. It's tapered at the end. It doesn't cut anything inside. It spreads everything. So what most people don't know is that your bodies are made up of what are called spreadable tissues. I don't mean, you know, Jeffrey Dahmer took that the wrong way. See, somebody can appreciate my sense of humor. I'm so happy. Thank you. Who is laughing over there? All right, good. You're get a raise. Just kidding. But spreadable means your tissues are fibers. They are literally like strings, very microscopic strings. Muscle fibers, fascial fibers, collagen fibers, elastin fibers, nerve fibers. I mean, you get the idea. We're basically very fibrous. Our skin is not, but the rest of us is. So what we do is we spread apart the fibers without damaging them. That's what real minimally invasive surgery can do. Everything else that's done is not minimally invasive because those surgeons are actually cutting things. Endoscopic surgery has the ability to be true minimally invasive surgery. Yes, I know this looks brutal. Look at the disc space starting to open up. Jordan, show us. Thank you. You see the white there? See the bones spreading apart? Shot? All right. So I'm actually using the dilator to spread apart the bones. Now I'm going to take the guide wire out because I don't want it getting pinched between the dilator and the disc. And we're going to go in a little further, and then we should be just about there. Careful with the other one. All right. Now we're bringing a tiny tube over the dilator, sliding it down into position, and we're going to do the whole surgery through this tube. Now, if you noticed, I've repositioned the tube already. This same tube I used at L4-5. Now I've moved it up to L2-3. I've skipped L3-4 because, like I said, I can't get the needle in yet. And by the way, she's perfect in terms of her depth. There's no muscle fighting. I'm not fighting the muscles to get in. The bones are spreading apart nicely. You'll only see this surgery done here in the United States at Deuk Spine Institute. Other surgeons don't know how to do this type of surgery. And that brings up a whole nother issue, which is training, surgeon training. Folks, I got bad news for you. The surgeons that are being trained today and that have been trained for the last 20 years are being trained to do highly invasive spine surgeries because they pay more. They pay more to the surgeon, they pay more to the facility, the hospital, they pay more to the companies that sell the screws and rods that go into your spines. The spinal cord stimulators, the morphine pumps, the devices, they're called device companies. Barricade device, biologics like bone graft or disc seal. All these companies promote their products to be put into your body, okay? You all know what the military-industrial complex is. The military-industrial complex are companies that sell weapons to our government or supplies to our government to use during war. Missiles, missile systems, rifles, bullets, hamburgers that cost 50 bucks. All that stuff is dramatically overpriced, and the industry actually drives war. Okay? I'm sorry, I'm not going to get political on you, but we all know there were no weapons of mass destruction. Yeah, we went to war and we spent $3 trillion of our taxpayer money. We were put into massive debt because of it. The point is, the companies like Halliburton made billions and billions of dollars in profits because we went to war. So there are companies that profit from selling either weapons or supplies to support war. They want us to go to war. They're promoting war. And they make money when we go to war. They don't make money when we don't go to war. We have the same problem in spine. The companies that have taken control of the spine industry are bribing surgeons, just like the companies like Halliburton bribe politicians to go to war, to buy their missile systems so they can make hundreds of millions of dollars in profit. It's the same concept. So our educational system in the United States has been hijacked by companies that make money putting things inside your body and leaving them there. They're called devices or implants, okay, or biologics. This surgery you're watching doesn't do any of that. It's natural. It's natural. We don't put anything in your body and leave it in there. We just put this tube in, the laser in to do the work, and then we come out. We're basically helping your body heal itself, okay? But this is bad for business. It's good for patients, it's bad for business. And, you know, fortunately for patients, it's available. Unfortunately, more doctors don't know how to do it and don't want to do it. They don't know how to do it because they don't want to do it, because they make 10 times more money doing fusions. All right, I know we got a lot of questions, so we may actually have the biggest backlog of questions we've ever had, right?
It's definitely one of them. We have a lot of questions.
All right, well, let's start wading through the questions.
This next one comes from Vitality Approach, once more on YouTube. And they ask, if someone is an acute flare-up and comes into you versus someone who flares up has gone down significantly, does this look significantly different while on the inside?
That's a great question. I mean, we got to keep this vitality around because they ask really good questions.
Agreed.
Yeah, so first of all, I have not noticed a difference that I can say is 100% accurate, but it's a great question. Now that said, I will tell you, when I see some people with disc problems that are acute flare-ups, I notice the disc is more swollen. Kind of like if you had a flare-up of knee pain, your knee is swollen, you know? And I think that's what the swelling, and not I think, I know it comes from edema, which is fluid inside the disc from inflammation. So the answer is yes, but it's not consistent. Now somebody like this person here, they don't have the edema. Their disc is so damaged that if you tried to make edema inside the disc, it would just leak out through all the tears, okay? And they don't have enough material left in their disc to make edema. It's basically gone. It's really dried up. There's nothing left. So what's really causing their pain is the tear in the back of the disc. It doesn't matter how old your disc herniation is. It could be that you have no disc left at all, except you will still have a tear that is painful. And that's why we're still able to fix it with the laser, because we're not doing a discectomy, we're doing an annular debridement. It's a very different type of surgery. Nobody else does it. We're the only ones in the world that actually do it. Now that said, there are other surgeons that have been watching me do this for years, and they're starting to do my procedure, the annular debridement, the Deuk laser disc repair. Of course, they won't call it the Deuk laser disc repair, because that's just human nature. they want to try to take the credit for themselves. And they're offering it in other countries like India, for example. I personally wouldn't go to India for spine surgery, but that's just my personal opinion. Nothing against Indians. I have a lot of them working for me. Dr. Patel is Indian. He's been around longer than anybody else. He's phenomenal. The problem is not the doctors. The problem is the resources. They don't have the supportive resources that you need. They don't have the quality control that you need to have a successful, safe spine surgery. So even though these procedures may be done in other countries, I don't recommend people go there to get them done because of a lack of critical resources needed for safe surgery. All right, next question.
Next question comes from Charles on YouTube.
Hey, there's a herniation. Yeah.
Charles asks, can you explain the difference between disc herniation versus disc rupture and treatment differences? Thank you.
Yeah, great question. So Charles, thank you for asking. A disc herniation is a disc rupture. There is no difference. As I've said 1,000 times, and I'll keep saying it, there are quite literally 10 different names for the same thing. A herniated disc, a bulging disc, a ruptured disc, a protruded disc, an extruded disc, a slipped disc. They're all the same. The disc is so simple, and yet we want to make it so complicated. It's not. There's an annulus and there's a nucleus, and that's it. Thanks. So that's my answer, and I'm sticking with it. Are you asking me if we have 5 minutes? Oh, on this disc? No, we're done. Yeah, this disc we're done. Yeah, I'm done with this one. Yeah, we can't use our betadine irrigation because she's allergic to iodine in a really bad way. So we're not doing the whole washing out thing you guys see me do a lot with that brown liquid, because that would potentially put her into an anaphylactic shock, which we don't want to do. Okay. We have finished 2 out of 4 discs. We've got 2 more to go. We're bringing our fluoro back in. Keep the questions coming.
This next one comes from Vitality Approach, once more on YouTube. And they ask, does any of that stuff you're removing contribute anything inside the existing disc, like keeping it from degenerating further, or is it the disc able to replenish itself after the tears heal?
Yes. So Vitality Approach. The material that we're removing from the annular tear is basically spent material. It's been destroyed and modified by the body. It cannot be put back in, and removing it does not in any way negatively affect the rest of the disc, okay? Not that we've ever seen in 17 years of doing this. The disc itself will heal. It will regenerate. What regenerates, though, is the outer wall, called the annulus fibrosus. What does not regenerate is the nucleus pulposus. The nucleus pulposus is not necessary. You don't need it. Sean? As a matter of fact, the nucleus pulposus is the remnant of the notochord. Embryologically, it's a tissue that controls the differentiation of all your other tissues in your body. It's actually the most important tissue in your body during embryological development. However, as an adult, it basically becomes a nucleus pulposus or cushion in the middle of your disc. And you don't need it anymore. Everybody thinks it's necessary, you gotta have a cushion there, but they're wrong. Because there's tons and tons of people with, show them the disc we're going to right now. Look at this disc here. There's no disc left. It's basically bone on top of bone. And this disc will become painless when I'm done with it. Basically, you don't need a cushion to keep a disc asymptomatic. there's lots and lots of people out there with zero back pain that have no discs left. They've got bone on bone, they've had it for years, and they've never had pain their whole life. They taught us that you don't need to have nucleus pulposus. And besides, if you needed nucleus pulposus, how come doing a fusion takes the pain away? Putting a cage in there takes the pain away. It's because you never really needed it. That's why. Hold on. Let me see. That looks really good. I'm going to take this guide wire out, and I'm going to try to advance this tube dilator without, at this point, into the disc space. Let's see if I can get in. Shot. Oh yeah, baby. Look at the disc space opening. That is cool. Look at the white color. That's called vacuum space phenomenon. So yes, we are going in. All right. Now I couldn't get it earlier because the patient was just too tight, too uptight. Too uptight. It's true. And now they're more relaxed with their anesthesia. So their muscles around the spine have loosened up, and it's allowing me to get into the disc space and separate the bones. Otherwise, the muscles would pull the bones back together and keep me from getting in. This is beautiful. It's not easy to get the tube in over the dilator, but we're making progress. Now the two are moving as one. All right, I better take some more questions because I heard we have a huge backlog of questions. Besides, Luis is going to have to use some muscles to see if he can get it. Is it coming? He's got it. All right, good. Shot? Wow. Luis, nice job. All right, questions?
This next one comes
Cold
from
welding.
this,
Cold
ne-
welding.
this next one comes from the Rose Stella on YouTube.
The Rose Stella?
The Rose Stella.
Nice. I like that. Well, the Rose Stella, Stella means star. The Rose Stella is a star rose? There may be a constellation. Okay. Go ahead.
I believe it is a constellation, but their question is I'm suffering with cervical kyphosis with C5 and C4 through C5, C5 and C6 disc protrusion.
Yes.
As per the doctor's suggestion, exercises, physiotherapy, and good head posture needed to reverse the cervical kyphosis. If I select the DLDR technique for C4-5 and C5-6, and after, are there any restrictions or complications while doing the cervical kyphosis treatment as mentioned above?
That's a great question. So, first of all, it is my belief, based on my years of treating neck pain and kyphosis and muscle spasms and herniated disc, basically everything in the neck that goes wrong, that your pain is not coming from cervical kyphosis. Your pain is coming from the discs or the facets which are causing you to have cervical kyphosis. In other words, the kyphosis is secondary to the source of pain, which is your disc or facet joints, or both. I would be able to tell you that if I saw your MRI and did an MRI review with you. We offer that as a free service to anybody in the world. And believe me, folks, we have people all over the world who do the Deuk Spine free MRI review every week. And we make that available for free at no charge, unless you're a very difficult person to deal with, then we start charging you. I'm just kidding. But in all seriousness, it's free. And all you got to do is fill out some questions so I have some information, and then upload your MRI or email it to us or send it to us. As a matter of fact, virtually all the patients you watch me operate on every week, they all did it. And that's how they're here. This patient is from Kentucky. They met me for the first time on the internet through an MRI review. And I figured out what was wrong with her based on the MRI and the physical exam that I did over the MRI review on Zoom. Okay? And then I recommended the treatment, and now here she is getting it done. Now, I'm confident in my diagnosis in this patient because I did the discogram, and I found that those discs are definitely causing pain. Her pain that she gets every day. It's called concordant pain. And honestly, I've done this long enough to know, you know, I'm pretty good at it. I don't mean to toot my own horn, but what I'm saying is there's a lot of doctors who can't figure out where pain comes from, but there's a few of us that can, and we're pretty good at it. And it's not that we're an anomaly, it's that we spent the time educating ourselves with our patients over the years on how to figure out where the pain is coming from, okay? And in this case, it's coming from these discs that we're treating right here. So in your case, I can't tell you if it's your disc, your facet, or both, or which disc, but I need to see your MRI and I need to do an examination. We do all that over our free MRI review. But your kyphosis is not the cause of your pain. Your pain is the cause of your kyphosis. I'm sorry. Unfortunately, a lot of therapists will try to convince you that they need to treat you with therapy and get your kyphosis fixed to get rid of your neck pain. And then after you've spent 3 to 6 months with them and they've taken a lot of money from you, that's when you figure out it's not working. And that's when they send you to a pain management doctor and they won't fix it either. So I'm just trying to save you a lot of time and trouble by giving you the truth, which is it's not going to go away with therapy. We can make it go away with this procedure. All right.
Next question comes from Jane on YouTube.
Uh-huh.
And they ask, degenerative disc disease can be treated?
Yes, this is degenerative disc disease, Jane. Jane, thanks for asking. She asked can degenerative disc disease be treated with this treatment? The answer is 100% yes. Every single disc we do is degenerative disc disease. This disc right here is degenerative disc disease. And we're going to take her pain away without doing a fusion. And that's why, right there, you guys see at 12 o'clock, there's some pink tissue. That is the inflammatory tissue, or AKA the high intensity zone. And I'm cleaning it out and removing this area with the laser. The laser will debride it. That's a bone spur, by the way. People ask me about bone spurs all the time. Yes, we can get rid of bone spurs too. Okay, here, I'll show you. This is bone spur removal. The laser has the energy to remove bone spurs. It's just about a matter of targeting them. And I don't remove bone spurs unless they're causing symptoms. This one is. It's literally sitting right underneath the nerve root that's leaving and going down her left leg. The nerve root is at the 12 o'clock position, right up there where the laser is. The nerve root is just outside of this metal tube. I'll show it to you in a minute, maybe. And you can see that the bone spur is literally right below the nerve root, pushing on it. Probably when I move the tube out, it will push on it. That's a bone spur right there. Okay? Let me finish cleaning out the bone spur, and we'll be done with this disc. Keep asking questions as I work.
Next question comes from Vitality Approach, once more on YouTube. And they ask, you mentioned in a video a while ago that patients who have been on THC are more difficult to work on. Is that the same with CBD without THC in it?
Let me ask my anesthesiologist, because the reason we said that is not because of the surgery part, it's the anesthesia part. They require much higher doses of anesthesia to make them sleep, and they fidget around a lot more. Right, Dr. Berndes? Yeah. So, did you hear the question, Dr. Berndes? If they're on CBD and they're not on THC, is that okay? Not a problem. Not a problem, Dr. Berndes. Yeah. Dr. Berndes is saying the synthetic THC is 100 times stronger and it's really bad. But, you know, a lot of people use it, unfortunately. But CBD is not a problem. Yeah. Dr. Berndes says that if you can take a break from it for a week or two before your surgery, it's better. What's that? A drug holiday is what they call it? All right. All right, just about done here. It's all scar tissue. right by the bone spur. I'm getting rid of the bone spur. Remember, folks, take a look at this tube. Remember, the tube itself is from the inside to the inside wall about 5 millimeters. So the laser fiber is 1 millimeter. So all this stuff I'm working on is sub 1 millimeter things, right? That's why you don't see the changes on MRI, because we're working at a level that's so microscopic that the MRIs can't see this. All right, I think we're just about done. Let me take a look and see if I can see the nerve root over here. It's going to be right over there. Huh? Got a little bit of bleeding. Let me just bring my grabber down. So it's in that scar tissue, in those veins right there. It's right in there. But anyway, I can't get a good visualization on it. Everyone's anatomy is a little bit different. But we got rid of the bone spurs. I'll do a little bit more right there, and then we'll be done. And we got one more disc to go. Keep asking your questions. Happy to answer them.
This next question comes from Jane, once more on YouTube.
Uh-huh. All right, we're done.
They asked, if a patient has had a discogram prior, will you need to do another one at a time, a procedure, or would you want those films?
No, it's a great question, Jane, about the discogram. We still do the discogram because we have to place the needle to do the surgery, and we have to inject the blue dye into your disc. But if you're worried about the pain that is produces during the procedure, then we could keep you asleep for that. It's not necessary. But basically, we still have to do a discogram, but we don't have to do a painful discogram. We call that an evocative discogram. We could just do what's called a chromo discogram. Chromo means color in Latin, and chromo discogram just means we're doing a coloring discogram where we inject the blue dye and the other dye, but we don't have to have you awake to see your response, if that's what you're worried about. And just so you know, all of our patients have anesthesia that gives them amnesia, which is a forgetfulness of the surgery, okay? So they don't remember anything we're doing afterwards.
I make sure of that.
Yeah, Dr. Berndes makes sure of that. It's pretty amazing, to be quite honest with you. But essentially, your temporal lobes are your way of encoding new memories, and Dr. Berndes has medicine that will not let your temporal lobes encode new memories. And it's just temporary.
It's called retrograde amnesia.
Yeah, it's called retrograde amnesia. It means it goes back in time. And the only thing you're going to forget is just the surgery. It's Versed, right?
Yep.
We use a little Versed.
Use on every case.
Yeah, Versed is an amazing drug. Don't know who discovered it. Sure it was an anesthesiologist. But the drug actually allows people to forget. They cannot store memories. I have the same problem sometimes getting older.
Extreme anxiolytic, the best one we have.
Yeah, and it's also for anxiety.
Yeah.
So it reduces the anxiety, and it helps patients not remember the surgery. So even if they happen to be a little awake for parts, they don't remember it. Yeah, we take very good care of our patients. Our patients love the care they get here. They love the staff. They're very happy with the service they get. Okay? Put pressure? All right. Any other questions?
Yes, this next one comes from Vitality Approach, once more on YouTube.
Sure.
They ask, if you wait 1 to 2 years pain-free, is there any chance of re-herniating then still?
Yeah, great question. So Fatality Approach says, hey doc, let's say you do the surgery and the patient's pain-free for a couple of years. Could they still re-herniate after that? The answer in theory is yes, but I've never seen that happen in 17 years. When my patients re-herniate, they always call me. They come back to me. So I'm aware of all of them. And I know when people reherniate, and I keep track of it. So I've never seen anybody reherniate more than 2 years after surgery. It doesn't mean it can't happen. It just means it's highly unlikely.
Your risk of reherniation is probably the same as any other disc after 2
Yeah,
years, right?
yeah. I think the risk of reherniation would be equal to any other disc, the normal disc. So I would say if it's happening, it's extremely unlikely and unusual. Okay, this is our last disc that we're fixing. Will be done in about 10 minutes with the surgery. And we'll still take questions. This is the L1-2. Remember, all of her discs were degenerated discs. They all started out with an annular tear, and then a herniation, and then a degeneration. It's just a progression of the same disease. Yeah, there's a piece of herniation right there. Now I could tell you already, looking at this disc, that there's more herniations. Like that right there, you see that? That is a piece of herniation. And we're getting rid of it, but it's different, isn't it, than the last one we did. When we did the disc before, the L2-3, there wasn't all this disc in there, was there? Remember, it was all gone. And that's because some discs, you know, they herniate and they degenerate faster than others. But it's all part of the same, what we call degenerative cascade, meaning that the original injury to the disc, which is trauma, caused the herniation, the annular tear, which then allowed the herniation, which then progressed over time to degeneration. Most doctors don't understand this natural history of a disc injury like we do. I don't know why they don't. They just don't have enough experience treating it. We treat this every single day at Deuk Spine. I've been treating it for 26 years. So I understand it. It's really not complicated at all. I mean, I had to figure a lot of it out myself by, you know, studying my results and my patients and doing endoscopic surgery and reading papers and reading books and watching surgeries of other doctors and just educating myself. I learned a lot about disc problems, and I put it all together with the endoscopic surgery. And honestly, endoscopic surgeons have a unique view into the disc because we're inside the disc. And it's not every endoscopic surgeon, by the way. Most endoscopic surgeons don't go inside the disc like we do. This is a technique that was developed by Dr. Tony Young. He's a Chinese-American orthopedic surgeon, and he taught me the most I know about lumbar, which is the lower back endoscopic surgery. He was a true master. He's retired now. His son, Chris Young, has taken over his business over in Phoenix, Arizona, and they do endoscopic surgery as well on the lumbar. They don't do what we do. They don't do the Deuk laser disc repair, unfortunately. And there's reasons for it, which I won't go into, but I'll just say that they're not in the patient's best interest. They're more financial. All right, questions? We're almost done. About 8 minutes left.
This next one is, I believe, either a comment and or seeking for advice. This comes from White Rose on YouTube.
Oh, wow. Got a lot of roses today.
Yeah.
I like it.
They said, I wish I could have known about your procedure. I had a C4-5 cervical fusion the entire time. It was misdiagnosed implant cancer referred to as squamous carcinoma. FDA came out to change it. So now it's mastized in the kidney, intestinal tract, uterus, besides implant area, caused unnecessary very expensive procedures. Now a giant bone spur is is like a hook up to my esophagus.
Oh, I'm so sorry, Rose.
Bone marrow is dead, screws are falling out, cauterized my L branch 3 set of 6 epidermal injections, labeled a criminal for their mistakes. I believe that given my personal experience, I was never able to figure out how to send my images because I don't know what the Dropbox to use. That is used, my state uses eHealth with Kaiser Institute.
Rose, Dr. Deuk, I'm so sorry what you've gone through, and I want to hear more about your story. I want you to share it with me. Henry's going to put a phone number.
Yes.
And I want you to contact Sam at this phone number. It's 321-775-1299. Sam's in charge of our MRI reviews. And tell Sam who you are and that Dr. Deuk wanted to speak to you. We'll set up a Zoom call. But I want to learn more about your story. Your story needs to be shared. I think, the misdiagnosis and the wanting to put fusion and do metal, it's all driven by the industry that we need to expose what's going on. So I'm asking you to contact Sam, tell her you're the White Rose, that Dr. Deuk wants to talk to some more, and she'll set up a Zoom call where I can meet you and see if I can help you as well. Sam may be able to help you get your images to me. If you're having pain, then there's something causing it, and I can figure out what it is, and there's a very good chance we can fix it, okay? But I also want to hear your story. So please contact Sam. Did you put the phone number? Who you are, and that I want to meet with you and talk about your problem. Okay?
All set.
Yeah. All right. This disc is pretty shattered, pretty dried up, degenerated. Doesn't matter. We're still going to fix the pain here, because the cause of the pain is not the dried up, shattered disc. It's the annular tear right here that I'm using the laser to clean up. Okay? You got about 3 minutes, maybe 5 minutes max. Keep the questions coming, and if I don't answer them in the surgery, I'll come and answer them for you after surgery. What is the next surgery anyway? Cervical. All right, our next patient is a cervical Deuk laser disc repair. He has a herniated disc in his neck, C67, and we're going to go in and fix one herniated disc, and it is gigantic. So you're going to get to see a big, big herniation.
This next question comes from Jane, once more on YouTube. And Jane asks, these procedures can't be performed with a pain stimulators in place?
Yes. Yes, Jane, these procedures can be performed with pain stimulators in place. I would still need to see where your generator is and where the leads are and make sure they're not going to be in the way. But we do them all the time. As a matter of fact, the lady we did last week on Thursday, if you go back and watch on our YouTube channel, she's from New Jersey. She had a pain stimulator in on her left side, and we did her Deuk laser disc repair on her left side. And we just worked around the generator. I went behind it, and I was able to still do the surgery. Now, some of these generators are in the wrong place, and they make it hard to do. But what I like to ask everybody that has a generator, stimulator generator, is try turning it off for a few hours, see if it actually makes a difference for you. Because the problem is a lot of these pain doctors are promoting the stimulators and putting them in patients even though they don't work. And they'll do things to you to make it seem like they work, but they don't actually work. And patients are getting them put in left and right. And it's all being pushed by private equity companies that own these pain management practices. They're buying them up left and right. And they're pushing the doctors to put in the stimulators because that's where the biggest profit margins are, even though they don't work. So a lot of people are getting recommended for stimulators when they shouldn't be getting them at all. And the companies, like, I won't mention names, but the companies that sell the stimulators are promoting the heck out of them to doctors. They're taking doctors out for steak dinners, they're buying them drinks, and they're, you know, getting them drunk. And the doctors aren't getting drunk and putting stimulators in, but they're whining and dining them and getting them to put these stimulators in patients like crazy. And the profit margins are absolutely huge on stimulators. Huh? I'm fine. The profit margin on a stimulator is usually around $10,000 to $20,000. Now, that $20,000, I mean, if you do brain surgery on a patient and take out brain tumors, you're going to get $1,500, maybe $2,500. And their profit on that is probably $500. So as a brain surgeon, like a neurosurgeon taking out brain tumors, you're making $500 for a surgery that takes 4 hours. Meanwhile, the pain guys are going in 1 hour and putting in a stimulator and making $20,000 profit, just to give you an idea of how much money they're making. I don't recommend stimulators very often. It's very rare that we recommend stimulators. It's really for patients that have no other choice. There's nothing else that will work. Did you change the irrigation? No, we're good. We're done. All right. I don't know why you're having trouble with it, but figure it out.
Thank you.
All right. What? Yeah, but why? It's a simple machine. It doesn't have a brain. It's not a teenager trying to fight you. You've just got to figure out mechanically why the pressure's low. All right, I'm going to come and answer your questions face to face. I'm going to show you the incision. Look at this herniation right here, Henry. You see this? Nice little chunk just laying around.
Yes, we do.
You see it's blue. It's blue because we stain it with the Deuk spine dye. And the Deuk spine dye will stain only herniated pieces of herniated disc, nucleus pulposus. It will not stain the annulus fibrosus. The annulus stays white. Scar tissue stays white. Here's another chunk right here. Okay? So we had a couple of chunks. You guys see these?
Yes, we do.
All right. So those are pretty good chunks. I think they came out of the last disc, the L1-2. Okay, you see that? All right. I'm going to give these over to Luis. And I'm going to show you all the incision. So we have one incision here, and we have another incision here. We had to do a second incision because I couldn't do all 4 discs with one incision. All right, type your questions up. I'll come answer them for you. We're going to close these up and go ahead and show our audience how the Deuk laser disc repair actually works. Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah, yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And
Okay, great. Well, we've seen that testimonial, so we'll cut it short and get to the questions since we have a lot. Just completed a Deuk laser disc repair procedure on 4 discs on a lady who's traveled from Kentucky.
Kentucky.
Oh man, I am so bad today. I apologize.
a long day.
Traveled from Kentucky. It has been a long day. And she has, like so many of our patients that come here, they've had already numerous treatments in the past, including shots, therapy, surgery, and in her case, she actually had a fusion done many years ago, back in the 80s. And I'm going to tell you, back in the 80s, we didn't really have a lot of instrumentation. They didn't have screws, rods so much. So a lot of the fusions were done what's called on lay, where the surgeon would actually get down to the spine and they would rough up the bone between the two vertebrae, and they would lay down iliac crest bone and then hope that those bones fuse together. And there was a lot of hoping and praying, and honestly the fusion rate back then with like an on-lay fusion was around 30%. So that's 2 out of 3 patients would not fuse, and they would continue to have problems like horrible pain, and they would have gone through a fusion surgery with no benefit. So the addition of instrumentation to fusion, and what I'm talking about is the addition of and originally with lumbar fusions there was the addition of a plate in the front of the spine, where you would bolt the plate to 2 bones and hope the plate would hold them so they're not moving around while they fuse. And so we call those ALIF, anterior lumbar interbody fusion, and the fusion rate went up to around 50% back then in the days, back in the late 90s. And then somebody developed posterior instrumentation. So instead of putting a plate and screws in the front of the spine, they started putting screws in the back of the spine that went into the pedicles. I mean, there was other systems too, like hooks and rods, and so those are like the old systems. But the pedicle screw fixation system evolved over time and got better, and the fusion rates improved even more. And then somebody developed what's called the PLIF, PLIF, which evolved eventually into the TLIF. PLIF is posterior lumbar interbody fusion. TLIF is transforaminal lumbar interbody fusion. And basically, we were cleaning out the disc from the back, cleaning the disc out, putting a cage in there, packing bone graft into the disc space, and then putting in screws and rods in the back, and then packing bone graft in the back of the spine. So you're really grafting bone in the back and the front through a posterior incision. And that was really the best way to do fusion. And it remains, in my opinion, the best way to do fusion. That's the only way I do fusions. I've done them all. I've done A-lifts, I've done X-lifts, I've done O-lifts, I've done T-lifts, I've done P-lifts, done it all. And the very best that works the most, is the safest, is the T-lift, as long as it's done properly. All right, well, this patient had a non-instrumented, meaning no hardware, not through the front, not through the back, just an on-lay iliac crest bone graft fusion, done at L5-S1, 1983. But she's continued to have back pain for 50 years. And she's had all kinds of treatments that don't work. There's lots of them out there. And she came here today for the Deuk laser disc repair. And I'm very excited for her. I tested her discs with the discogram, and indeed, they were causing her horrible pain. That was the pain she gets every day. So I feel really good about the results. We don't have them yet, but she'll be awake soon. Tomorrow she'll come in and we'll see how she's doing. All right, questions?
Okay, this first one comes from Premier Media Group on YouTube.
Premier Media Group, becoming a regular.
Yep.
Nice.
And they asked, Doc, have you found any dietary or supplement changes to help promote healing of the annulus post-DLDR procedure?
Yeah, great question. You're asking, Doc, has your team looked at any kind of dietary or nutrition aspects to healing the annulus fibrosis? I have to admit the answer is no, I have not. And it's not because there aren't any. It's probably just because I'm kind of busy doing a lot of other stuff and I haven't really dove into it. I'm really not the snake oil salesman type. I don't like, get a bottle of this supplement right here and your disc will heal faster. I only sell what I actually believe works for people. And so I don't want, first of all, it's a complicated answer, right? Because there's so many supplements out there. How do you test them all? How do you determine if they're actually working? And so I guess that's really the main thing is, I don't really have a great way of seeing how quickly it heals the annulus. I mean, you'd have to like basically put a scope back in the patient and maybe bounce something against the annulus and see how strong it is. But the moment you're doing that, you're getting invasive on the patient. You're exposing the patient to risk that's totally unnecessary in my opinion. So I guess what I'm saying to you is the reason I don't have an answer about nutrients and vitamins and minerals and whether there's ones that will heal the annulus faster is not because it's not important. It is important. But I don't think there's really a reliable way of testing it that I've thought of in my limited amount of time I've had to think about it. So is it a worthwhile thing to pursue? 100%. I agree it is. But how do you use a non-invasive test like an MRI, X-ray, something to be able to determine if that annulus, like what percent it's healed, right? And there is nothing that I know of that exists today that can do that. There's no test. So because there's no reliable test, I would never feel good about selling something to you guys or promoting something that I wasn't sure works. All right.
This next one comes from Felix on YouTube.
Hello, Felix. I like that name. Reminds me of Felix the cat, right?
Yeah.
Felix the cat.
They ask, does the patient have does this patient have spondylolisthesis on L5? I had an ACDF C5, C7 5 months ago, and I had a mild cervical myelopathy and was recommended an ACDF. I regret it since now that I have 2 cages. Pain is worse than before. Do I have any hope to be pain-free?
Yeah, Felix. So thanks for sharing your story. I would love to hear more from you. I'm actually, truth be told, we are doing a study. I'll just call it a study, but we're gathering information from patients who have had their surgeons promote spinal fusions, instrumentation, stimulators, pumps, basically implants. We want to hear your stories. And you can contact Sam at 321-775-1299. 321-775-1299. Tell her, my name's Felix, Dr. Deuk told me to contact you. He wants to interview me about my fusion. Okay? We're trying to gather more information and more stories from people. There's a lot of unnecessary fusions being done. And I want to hear people's experiences individually. So if you have time and interest, if you're out there and you've had screws, rods, cages, plates, metal, something foreign put in your body by a doctor, and I want to hear about it. I want to know more about it, okay? As far as your pain goes, absolutely we can get rid of your pain. No doubt about it. Felix, the chances that you're hurting from where they did your surgery is very low. On a scale of 1 to 100, it's a 1. 99%, you're hurting from above the surgery or below the surgery. And it's either the disc or facet joint above, below, or both. I can figure that out quite easily if I can do an MRI review with you. But I've got to see you. I've got to have you show me on your neck where you're hurting. I've got to look at you. So I don't just look at the MRI, I look at you. And you're going to tell me where you feel the pain. If you can do that, which I know you can, then I can tell you exactly how to fix your pain and cure it permanently without any more invasive surgery. Just do the MRI review, free MRI review. It's mri.deukspine.com. Henry's going to type it in right now. But remember, call Sam, 321. That's 321, liftoff. That's because we're in the Space Coast of Florida. We're right next to NASA. You could see the space shuttles in the old days. Not so long ago, they were literally right over there on launch pad A and B, and I watched the space shuttles launch. You could feel the whole building shake when it did. So that's why we're 321-775-1299, and I'd like to hear your story.
All right, next question comes from, these next questions come from Vitality Approach, once more on YouTube.
I will say one more thing, Felix. We're about to do a cervical Deuk laser disc repair. So watch the next surgery. We'll start it in about 40 minutes. and I'm going to go in through the front on the right side. I'm going to make a little cut, 4 millimeters here. I'm going to go down to the herniation and use a laser to remove the entire herniation. And it's a big one. And we're going to get that thing out with the laser.
Alright, these next few questions come from Vitality Approach, once more on YouTube. And
Vitality approach?
Vitality Approach.
So it's not fatality approach, it's
No,
vitality. Vitality approach. All right, very good.
Their first question is, why would this dead tissue cause spasms along the nerve path? Is this a chemical reaction irritating the nerve?
Yeah. So vitality approach, you are correct. What is happening is the annular tear and the nuclear material stuck in there. The nuclear material causes inflammation to set in. The inflammation causes the little nerve fibers around that area of the tear to be activated and send pain up to your brain. So yes, it's a chemical reaction that irritates the C fibers or type 4 fibers, which are pain fibers, and they send pain signals up to your primary somatosensory cortex on the opposite side of the body, and you feel that pain very localized right where the herniation is.
Next question from Vitality. It asked, is there any pain in the bone itself after removing a spur that the patient would feel?
Is there any pain in the bone itself after removing a spur? No, absolutely not. Bones do not really have much in the way of innervation. The covering around the bone is called the periosteum. It does have nerve fibers, but the bone itself does not. So bones do not really hurt. We do screws and rods, where we put these screws and rods in the bone all the time, and patients never have pain from that. Their pain comes from the muscle around the spine.
And next question from Vitality is, if pain comes from chemical inflammation from the degenerated disc, then are bone spurs at all responsible for the pain?
And this Vitality is very smart.
Yeah.
I love it, Vitality. I don't know who you are, but
Great questions.
yeah, you are really understanding this stuff. You are correct. Bone spurs do not cause pain. Now you understand my frustration. I'm always dealing with people with bone spurs. I want my bone spurs removed. Bone spurs do not cause any pain whatsoever. What bone spurs truly represent is this. There's a battle going on, okay, for neck and back pain. It's a battle between the doctors that don't do surgery and those that do surgery. Kind of like werewolves against vampires, right? And they hate each other. The surgeons pretty much hate therapists and chiropractors. Chiropractors and therapists pretty much hate surgeons. Give me 1 sec. Karen? Yes, extra large cheese. Oh, pepperoni. Just kidding. Nobody on the phone. So Vitality Approach, this battle that's going on between surgeons and non-surgeons, the therapists, the chiropractors. So here's how the conversation goes. Okay? And this is not me. This is other doctors, surgeons. Here's the patient. But doctor, why do I need surgery on my spine? Why do I need a fusion? Doctor, surgeon. Because you have bone spurs. Therefore, you can't do therapy. Physical therapy won't take bone spurs away. Chiropractic therapy won't take bone spurs away. Patient. Oh, I see. So the bone spurs are causing my problem. Yes, they are. Ah, okay. Fuse me. Okay, this is literally what's happening. I was an actor. I played a few roles in high school. Not a very good actor, but I was okay. Point is, if you're this spine surgeon who wants to do a fusion surgery on a patient, and the patient's being a pain in the ass and not doing what you're telling them to do, all you got to do is show them the bone spurs, and then they get scared. And they realize, oh fuck, therapy's not going to work because I got bone spurs. Chiropractic can't take away bone spurs, but the surgeon can treat it. Well, guess what? Those surgeons that go do a fusion, And if you look afterwards really carefully, you'll still see the same bone spurs are there. Okay, I'm laughing about it because it's so ridiculous. I see this all the time. It's just I don't know, it's like a play that just plays itself out over and over again all around the world. I don't ever tell patients they have bone spurs, they need surgery. What I tell people is the truth, which is you have a tear, there's a herniation, it's causing inflammation. I'm going to go in there and clean the tear with a laser. All right, so there's your answer.
This next one comes from the Rose Stella on YouTube. And they said one of my friends had a L4 to L5 degenerative disc and getting leg pain and weakness on both legs. And there is high movement showed between the disc in the normal X-ray and forward bending posture. So what kind of approach do you offer him for this? And does high movement between the discs stop you to treat him, or your procedure will work as usual?
Yeah. So the Rose Stella, thank you again, great question. Your friend could be treated with the laser surgery completely successfully, one surgery and done. Your friend has movement at the disc, okay? First of all, movement at the disc is normal. Everyone should have movement at the disc. We want movement at the disc. The surgery we do treats the disc in such a way that we get rid of the source of the pinched nerves, the herniation. If there is a bone spur pinching the nerve, we'll take care of it at the same time. But 98% of the time, it's a herniated disc, scar tissue from the herniated disc. Okay, we can get rid of all that with the laser surgery and preserve the movement without fusing. And the pain and in the back and the legs will go away. So your friend is still a candidate unless the movement is like massive amount of movement. So I would say if he has 15 millimeters of movement documented, then the laser surgery would not be the appropriate treatment. But 15 millimeters is, you got to see about that much movement between the bones. That's a lot. Okay? Great question.
And last but not least, our last question is from Vitality Approach, once more on YouTube, asking about what's your opinion on Tony Mork's theory that disc injury causes end plates to create hardened nucleus fragments that get pushed into the wall and cause tear?
Okay, well, Vitality Approach, I know Dr. Mork very well. Dr. Mork and I met many times. Believe it or not, we met many times in Arizona at Dr. Anthony Young's disc center, where Dr. Tony Young taught the transforaminal endoscopic approach. And Dr. Mork's an interesting guy, but to answer your question, if I've watched Dr. Mork's videos, I know Dr. Mork, I don't know him that well, but if Dr. Mork is saying that the bones are causing the disc to fragment, and that's pushing against the annulus, which is causing a tear, I don't agree at all with that. The first step in all disc injuries is the annular tear, and it comes from trauma. So a massive force suddenly shocks that disc and tears the annulus. At the same time, it crushes the nucleus next to the annular tear and fragments the nucleus. Once the nucleus has been fragmented and damaged next to the tear, now pieces of that can push out through the tear and cause the herniation. That is my explanation, and our new website that's going to be launched in a couple of months is going to show you exactly how that happens in our animation. It's already done, the animation is completed, but the website is going to cover lower back or lumbar, it's going to cover cervical, it's going to cover thoracic, and so we're already done with the lumbar section, but we're building out the cervical and the thoracic and a few other sections. I am personally overseeing, yes, I am personally overseeing every single word and every single diagram and every single animation. And I'm editing every one of them. So the website is truly my creation. I just have a lot of good programmers and artists that are helping me overseas to create this site. And it is going to be one of a kind. There will be nothing on earth like it. And it is going to explain all of these conditions, as well as the treatments, the pros and cons of each treatment and how the treatments work. It's going to be incredible. And we're going to have a virtual chatbot, virtual human that people can interact with natural language, where we have an AI platform that will answer all your questions. So I'm very excited about the site. The AI platform will not be there at the launch, but the website will, and we're going to build into it the AI platform over the next couple of years. I've already hired the programmer to do it, and I have a team working on it. And here he is.
Okay. This is now the final question. This
Do
is
you
from
need me?
You need?
I'm in the middle of the live
Yeah,
stream.
this is the last question from the Roses Stella once more on Facebook, asking, this is my follow-up question to my first question. After C45 C6 DLDR technique, can I start exercising?
Yeah. So if you've had the surgery that we're doing here, the Deuk laser disc repair, remember, we're not putting metal, we're not putting any cadaver bone or biologics or any of this other junk that all these other surgeons want to put in you. It's natural. So your body will be able to heal the tear after I clean it out and help it. But it takes 9 months to a year to fully heal your tear. Okay? The tear will heal slowly after we clean it out, because there's not a lot of blood supply to that area. And your body uses blood supply to help heal. Think about your blood supply as being like a highway or a train track, right? It's a way of transporting materials to an area that needs those materials in order to rebuild. And what's rebuilding is your annular wall is going to rebuild. But the problem is you're rebuilding an entire city from a tiny little road that the cars have to go, a single lane road, right? So you got to bring these trucks with cement and steel and glass to rebuild, but they've got a little tiny 1-lane road. So there's not enough blood supply to the disc to let it heal fast. There's lots of blood supply to your heart, your brain, your skin, your kidneys, but there are tissues in your body that have virtually no blood supply, and they rely on something called diffusion, which is the passive movement of molecules down a concentration gradient, and that's very slow. So 1 year after your surgery, you can do whatever you want. The disc will be completely healed. 12 months. You can go bungee cord jumping, skydiving, you could do Greco-Roman wrestling, whatever you want to do, you won't hurt your disc.
And that is it for questions.
All right, I hope you enjoyed the surgery. We're going to cut it here. We've got the next one is a single level cervical DLDR for a herniated disc C6-7, big herniation, and then our last surgery will be a lumbar. So we'll see you back in about 30 minutes.